So I'm very happy that Henry gave an excellent introduction into this particular minimal invasive portion of our webinar. And I want to carry this one step further and briefly talk about a technique to make sure it doesn't get into obliviation, because not everybody is familiar with endoscopy at the beginning of their career. And some of us may be already familiar with stereotactic techniques. And I want to offer a couple of pearls of most minimal invasive treatment for a similar problem.
Are you going back to work?
Very technical, but requires a simple answer. So I have nothing to declare. I want to show you three scenarios where stereotactic treatment of CSF flow or cyst flow reestablishment can be chosen. One is unilateral hydrocephalus from entrapped temporal horn, as Henry had mentioned briefly. Then obstructive hydrocephalus from quadrigeminal plate arachnoidal cyst, and obstructive hydrocephalus from cavum vergae. I want to take you through clinical problems, conceptual problems, and the available treatment solutions. So first, let me briefly talk about, yes. So let me put the mask back on. I hope you can still hear me. So hydrocephalus in these cases occur secondary to lesions that obstruct the CSF flow. And it's usually somewhere in the atrium that the outflow obstruction occurs. And everything that is in the inferior portion, the temporal horn, continues choroid plexus and can create unilateral entrapment of the temporal horn with sort of focal hydrocephalus. These lesions can be neoplastic. We see that in cysticercus infections and some other tapeworms, inflammatory diseases, or hemorrhagic lesions. This is how three of these examples look. On the upper left, you see a meningioma of the atrium. On the upper right, you see a solitary fibrous tumor of the choroid plexus. You see a post-surgical hemorrhage, which can also happen spontaneously. And all these lesions have in common that you get a unilateral entrapped temporal horn, which may be symptomatic. So what is the clinical problem? There's stretch on the parenchyma of the meninges and the surrounding brain on the afflicted side, and it can compress Meyer's loop, the internal capsule, and the hippocampus. If it's a neoplastic problem, these patients often present late in their course of disease, and most common presentation actually is that the patient is just presenting with headaches, sometimes with ipsilateral tinnitus, but there may be contralateral hemianopia, contralateral hemiparesis, and on the left side, you often find a more prominent cognitive decline and even dysphagia. What are the treatment strategies we've heard about throughout the day? Well, you can do temporary external drainage if it's urgent, place an EVD, and then follow with open surgery to the actual pathology. And that would be preferred in many cases. You can do conventional shunting of the entrapped temporal horn, which is rarely done, but described in the literature. There's an interesting concept of frontal to temporal horn shunting, placing two catheters in the ipsilateral side and connect them by a U tube so that you get equilibration of the entrapped temporal horn and the ipsilateral frontal horn. But you have to tunnel. It's similar to a shunt, though it's missing a valve. And you could go endoscopic and fenestrate the choroidal fissure, or, as Henry has shown, the suprachiasmatic cistern. But how about placing a lateral ventriculocysternostomy? So I want to show you this first and briefly talk about treatment constraints of the conventional options. If you place an EVD in open surgery, obviously you have two surgical interventions, which translates into higher morbidity. But if you can fix the primary neoplasm, that would be the way to go. If you place a shunt into the temporal horn, there's a chance of a device failure, which can be proximal at the level of the shunt valve or distally. And there's a risk of seeding if it's in a neoplastic case, let's say a metastasis to the choroid plexus. So I wouldn't prefer that. Frontal to temporal horn shunting has largely been abandoned because it's two surgical access sites and corridors, which increases your risk. And endoscopic choroidal fissure fenestration was nicely described by Andrew Perrin here from London, but carries a higher morbidity, and there's some risk for vascular injury and induced visual compromise and reclosure. So often people stay away from this. So what I want to proposes you can make your approach the least invasive and either do endoscopy, as Henry has shown, or you can do stereotactic intervention and aim for the highest quality of life with the most minimal invasive procedure, which I think is very helpful, especially in neoplastic and malignant disease. So this is my example because I thought it would never come to a surgical intervention. This was a 41-year-old female patient who was diagnosed with meningiomatosis of the atypical version. She already had 4 prior craniotomies and did not want to have any further surgeries. When at surveillance MRI scans, she showed up with this tiny meningioma in the atrium of the right-sided lateral ventricle. She was a lawyer, had a KPS of 100, and was without focal deficits when we discovered this. So obviously, what would you do? We didn't do anything. We followed her sequentially. And to our surprise, a few months later, she presented with new onset headaches and a size progression, just 3 millimeters of this lesion, but it clearly had shown a ipsilateral and trapped temporal horn. So we still didn't know what to do because we didn't want to go through slit ventricles and explore this. So we first put on steroids. We thought maybe this is inflammatory. It didn't go away. And after 3 months, she came back and said, I want to get this treated, but I really don't want to have open surgery. So we decided to a stereotactic catheter placement for internal shunting. And although this may sound a technical overkill, I think it's a very safe procedure and someone who is familiar with stereotactic techniques. It gives you defined working trajectories. It is very short surgery, very short length of stay with minimal morbidity. And it's all about pre-surgical planning. So we do these cases in a fixed frame. I wouldn't do this freehand with the image guidance system only. We put the patient into a frame and measured the distance of the expected catheter from the entry point of the bone in the temporal squama to the prepontine cistern. If you get your angles right, you can place a single catheter that is pre-perforated and actually end up in the prepontine cistern. And the patient did stunningly well. And we then treated her meningioma post-operatively with stereotactic radiosurgery, which allowed us to have 2 minimal invasive procedures of 1 hour each with no morbidity. And the result was nice. After single fraction treatment of stereotactic radiosurgery to the meningioma showed complete local control, and the temporal horn had been successfully treated with our catheter implant. So from a legal risk perspective, in this case, she was a lawyer. She wanted to have minimal invasive surgery. We delivered, and I think this is a successful outcome. Conclusion, this approach takes advantage of the proximity of the temporal horn to the prepontine cistern. The topography gives you a near orthogonal trajectory to connect the 2 compartments. And if you come in from slightly posterior, your chances to hit Meyer's loop and create a major visual deficit is much less than with any other technique. It does obviate the need for endoscopic manipulation. It does not require multiple catheter placement as in the 2-shunt technique, and you don't need to tunnel anything subcutaneously. So it's a simple procedure, just with a lot of technology required. Second scenario, obstructive hydrocephalus from an arachnoidal cyst of the quadrigeminal plate. So an extra-axial lesion compressing the aqueduct. These arachnoidal cysts are very common. They are developmental abnormalities, and they present with some fluid that is trapped in the cystic structure. And for some odd reason, some of these arachnoidal cysts can grow like a valve mechanism. There's an ongoing debate how to treat them best, and you would only treat symptomatic lesions. And lesions can be associated with hydrocephalus in various locations. So the most frequent ones are suprasellar arachnoidal cysts. Then there are infratentorial arachnoidal cysts. And in this case, I want to show you a case of a quadrigeminal arachnoidal cyst with aqueductal obstruction. Again, there are 3 treatment strategies that come to mind. You can address the causative lesion and basically take care of the arachnoidal cyst through open surgery and fenestration of the cyst, which can be done microscopic or endoscopic with a ventriculocysternostomy or a cystocysternostomy. You can also do focused shunting of the cyst, which is difficult in this location. You can symptomatically just treat the resulting hydrocephalus if a patient is not fit for surgery and do a conventional shunt or an ETV. or any combination of the above. Again, there are treatment constraints. Endoscopic or open surgery has a high rate of closure and cyst recurrence. In the literature for arachnoidal cysts, the reclosure rate is almost 40%, although with better endoscopy techniques, I think the modern number may be much lower. VP shunt we talked about has device failure risks and infection risks. ETV, again, there are some procedural risk with a larger endoscopy access point here and reclosure. And combination surgeries carries higher morbidity. So here's my case. It's a 31-year-old female patient who is a circus artist. She was diagnosed with holocephalic migraines and an initial KPS of 90. She then developed nausea, vomiting, dizziness, and vision problems, and came into the ER in rather dire circumstances. So this patient went to the ER and showed this rather unusual but typical dumbbell-shaped arachnoidal cyst. We got a DWI on MRI scan to make sure it wasn't an epidermoid. And you can see how much mass effect is exerted on the aqueduct as well as on the fourth ventricle, and there's even a secondary Chiari. So she was diagnosed with a mixed supra and infratentorial cyst at the level of the incisura. Because she was in the ER and really not doing well, we decided to place a frontal EVD for emergent treatment, and opening pressure was 35. The headaches immediately resolved, and then we admitted her to the floor for further treatment planning. Now, normally, I would say this is a beautiful case of the P fossa, and I'm a fan of supracerebellar infratentorial approaches, but things are rather crowded at the back of the skull here. So open resection and fenestration may be challenging in this setting. And the same is, I think, true for endoscopic fenestrations. So the idea of internal shunting came to mind, which is not new. And there's an excellent paper by the group of Chris Ostertag that I show you in a second. So this is what we did for surgical planning. We planned this in 2 steps. We did a frame-based stereotactic cyst puncture first. Here you see the patient in the stereotactic frame. We aimed for the middle of the cyst, put a guide tube down from the top down, which is roughly the coronal suture, 2.5 centimeters to the side. And we then, afterwards, after we had achieved successful cyst aspiration and let's say 40% of aspiration, we placed an internal cystoventricular cystostomy shunt, which is again an internal stent used through a Holter catheter connected to a Rickham reservoir that the shunt doesn't migrate. So you can see, aspirate the cyst first, plan the trajectory, place the catheter in there, and then wait and watch and see what happens. And here you can see what happens. This is the ER presentation scan, 3 days post-surgery with the shunt, internal shunt in place. The arachnoidal cyst is already deflated, and at 18 months follow-up, there's near resolution of the arachnoidal cyst, and the patient was symptom-free. So the conclusion is there are many treatment options available for this condition. So why would you add another one? I think sometimes you have to pick the least invasive approach for the highest quality of life. She did not want to have a neck dissection from a posterior approach because she was an artist working with physical performances in the circus. I did not feel comfortable doing this endoscopically from the top down. So I thought this was a good approach, and I think it served the purpose. Last scenario, obstructive hydrocephalus from cavum vergae or septum pelludeum cysts. So this is a beautiful paper by my old group in Freiburg. Christoph Ostertag actually collected 26 midline congenital lesions and wrote them up in this paper in ACTA. This is the typical example I want to show you, a cavum vergae that is a developmental abnormality with ventricular dilatation by obstructing the foramen Monroy bilaterally. By placing a simple catheter through the frontal lobe, through the ventricle, into the cavum vergae, you can achieve decompression of the cyst, and the patient became symptom-free from headaches and seizure to nothing thereafter. In their paper, they described 27 such procedures, out of which 6 were cavum vergae and septum pelludeum cysts. They had an excellent success rate in their overall series and only minor complications. And I encourage everyone to read up on this, to have it available in your armamentarium as a minimal invasive procedure for a rare problem. So my conclusion is, for certain cases, less is more. We have learned from open surgery to go more to endoscopy. Sometimes we can go one step further and go from endoscopy to minimal invasive stereotactic catheter placement. And I hope this was a good example for you to keep this on your mind. Thank you very much.
Thank you to you. It was a really a very good presentation, and I think that your conclusion, do what is better for the patient and don't go ahead. Any comments? Questions? No one?
Good. I sign off for now.
I think I make a comment. I think that your mention of stereotactic approach is very important, because stereotaxy it was overcome by endoscopy, it was overcome by neuronavigation, but still is a technique that can, in less cases than in advance, but it can be very, very useful.